First up, we've got Dr. Ingrid Hoeritzauer, who is a researcher in Edinburgh, having a neurologist who trained in Belfast and has been doing amazing work, pushing back the boundaries of our understanding about urological symptoms, and particularly functional urological symptoms. So thank you so much, Ingrid, for coming.
Hello, good morning, everybody, and I'm absolutely delighted to be at the BNPA and presenting about functional urological disorders. And this talk will mostly sort of centre around chronic urinary retention and urinary retention in general. That's most of my research is about. So I have got to say that before I did any research into bladder disorders, I pretty much thought that it was just a fancy bag. I mean, I knew it didn't have polka dots on it, but that was sort of the height of my understanding of it. But it's actually really a fascinating feedback mechanism between internal and external urethral sphincters, the bladder, the sacral cord, pontine maturation centre, periaqueductal grate, and then this higher cortical network. And I'm just going to focus just really on two bits of this. So the first is the external urethral sphincter and the pelvic floor, which are skeletal muscle and under voluntary control. And the other part I want you just to sort of bear in mind as well is the sort of higher cortical network, which includes the insula, the prefrontal cortex, and the anterior cingulate gyrus. And basically what this higher network is answering are two important questions. The first one is it safe to void? And the second one is it socially appropriate? And we'll come back to why, again, those are important later on in the talk. So why do we even think that functional bladder disorders exist? Well, Charcot said so, and he's usually right. But actually, up until the 1980s, psychogenic urinary retention was sort of a relatively common diagnosis. And in fact, as part of DSM-3, idiopathic urinary retention was one of the pseudo-neurological symptoms that was part of the diagnosis of somatization disorder. Also, more recently, Mark Edwards says so, and he's also usually right. As part of looking at patients with functional movement disorders, they looked at 150 patients and found that about 20% of them had bladder symptoms. And basically, what they found was that the people that were most affected were those with functional dystonia, and the most severely affected patients also had urinary retention. But my supervisors are Scottish, so they don't trust anybody, so we, of course, had to check this out ourselves. So we did a study looking at 132 patients attending outpatient neurology clinic. We found that about a third of them had functional disorders, and about 66% of patients, both with pathophysiological neurological disorders and functional neurological disorders, had urinary symptoms. But the big difference was the women. So actually, in women with functional disorders, 45% of them had low stream symptoms, compared to only 15% of patients with neurological disorders. So this all suggests that urinary retention, chronic idiopathic urinary retention, perhaps acute urinary retention, could be part of a functional neurological disorder. So why did it disappear from the lexicon? Well, it all really happened in the 1980s whenever Claire Fowler and her colleagues were worried that women were being diagnosed with psychogenic urinary retention, they weren't being properly investigated, and they were effectively just being left to rot, have a catheter put in, and that was about it. And they saw that these were young women in their mid-20s and their mid-30s, and they had painless urinary retention of over a litre. They had these incredibly uncomfortable gripping sensations during intermittent self-catheterization, so bad that a large proportion of them actually ended up with suprapubic catheters. And also they had these very abnormal findings on urethral sphincter EMG, so complex repetitive discharges and decelerating bursts. And also to their mind, it seemed like the triggers made this very likely to be pathophysiological, so things like surgery, urinary tract infections, etc. And I just want to play a little snippet of what the EMG sounds like. Okay, that wasn't very exciting, but maybe it's supposed to sound a bit more like the underwater singing of whales. So I did earlier, and now it just sort of sounds like, but anyway, it does, trust me, that's what it's supposed to sound like, the underwater singing of whales, these decelerating bursts. And people started to ask, actually, more recently, is this just kind of a diagnosis that was made in order to save patients, but actually, with our new understanding of functional disorders, would it be better to put them back into this category? And there were a couple of reasons why. one of them was that obviously there's not a massive database of women's urethral sphincter EMGs hanging around. So people weren't sure whether or not these changes were part of normal women's physiology or whether or not they were actually part of Fowler syndrome or this sort of chronic idiopathic urinary retention. And another reason was that there seemed to be a lot of sort of functional comorbidity associated with it. The other thing as well was that Claire Fowler and colleagues had sort of wondered whether or not this could be due to an estrogen-sensitive channelopathy. And the reason for that was a lot of patients seemed to have polycystic ovarian syndrome. Now, more recently, what we find is that actually the prevalence of gynecological abnormalities in women with Fowler syndrome is the same as the population prevalence. And there's no evidence of any estrogen-dependent channelopathy or any channelopathy in general. The other thing is as well that actually whenever they looked, they found that actually these changes are not specific to patients with Fowler syndromes, so women can have them just at different times in their menstrual cycle. What we did, however, find was that there definitely is a hint here of functional disorders. So in terms of half of the patients, whenever we looked at 62 patients that had been diagnosed gold standard Fowler syndrome, had unexplained chronic pain, usually abdominopelvic. A quarter of them had functional neurological symptoms, and 20% of them were on opiates. And whenever we're looking at whether or not urinary retention could be a functional disorder, we've got to think about, are there any others? And this is definitely a functional urinary retention syndrome, and it is caused by the hell that is men's bathrooms. I do not know who designed them, but you're mean to each other, right? So basically, paruresis or shy bladder syndrome is the inability to void whenever you're in the company of others. And this is quite typical for many people. If you're in a very quiet stall, you might kind of just try to flush the toilet so no one can hear you. But for people that have this in the most severe part, actually they've got worse quality of life, they have severe limitations to social activities, to travel, to occupational things. And this affects about 7% apparently of the population. But in the last 5 years, there's only been 6 papers on it. And that's because it falls right smack bang in the middle of psychology and urology. And that means really almost no one's touching it. So this is definitely a functional urological disorder that responds brilliantly to CBT and causes urinary retention. What about acute urinary retention? Is there any evidence that this could be a functional urological disorder, or at least some of the patients could have functional urological disorder? Well, the way we looked at this is with Cauda equina syndrome. Cauda equina syndrome is a clinical and a radiological diagnosis. So you've got to have more than one of either bladder or bowel or sexual dysfunction, saddle anesthesia, and then possible neurological deficits in the lower limbs. But you've also got to have radiological criteria which show that there's a reason for the dysfunction of the Cauda equina nerve roots. And actually, what's surprising is that even in experienced neurosurgery registrars, they can only get the diagnosis right about half of the time based on the clinical symptoms. So patients that have got normal MRI scans have almost exactly the same symptoms as people that have got abnormal MRI scans that need an emergency operation in the middle of the night. And we looked to see whether or not there was any evidence, first of all, in a pilot trial. So is there any evidence that some of these patients with scan-negative Cauda equina syndrome could actually have a functional disorder? And we found that 90% of them, it's a very small study, but 90% of them had Hoover sign of positive leg weakness. And as well as that, you can see a trend towards more dissociation and higher likelihood to have symptoms of a panic attack. We then did a larger retrospective study of 276 patients. And as you can see, it's about 70% of people that actually have this scan-negative Cauda equina syndrome. So most of the people that were waking up the radiologist in the middle of the night to scan do not have Cauda equina syndrome. They have something else, and something obviously very important and very distressing. And we looked then, so we divided them up in order to try to sort of work out whether or not there was a difference between patients. So we looked at patients that are scan positive, so they've got the clinical and the radiological. Then we looked at patients that have got scan-negative Cauda equina syndrome, but also have got nerve root compromise. And then we looked at patients that have got totally normal MRI scans. And as you can see, the rates of functional disorder increase incrementally. And also, people are left really disabled. 50% of people ended up at follow-up with chronic back pain. So my PhD study has really been looking at patients admitted and trying to sort of phenotype patients in more depth. And we've looked at patients that have got scan-positive cauda equina syndrome, and again, divide up the scan-negative patients into those with nerve root compromise and those with totally normal scans. As you can see, 75% of people have got scan-negative cauda equina syndrome of one type or another. And the things that people spend a lot of time looking for, and the things that people, neurosurgeons are my friends now, and they spend a lot of time shouting at people over the phone because they haven't done these things. So done pinprick sensation to saddle numbness, done a PR examination, or done a post-void bladder scan. And actually, there's no difference in any of these three groups. There's no difference between any of these clinical signs that we spend all our time looking for. And also what I want to draw your attention to is the fact that a third of patients with scan-negative cauda equina syndrome have got good going urinary retention of over 500 mils. What is, however, really interesting is that a lot more people have got signs of a functional neurological disorder. So 11% in scan positive, which that's sort of what we would expect. About 1 in 10 people with a pathophysiological neurological disorder will have functional overlay. But then look at the nerve root compromise, 34%, and then look at those patients that are scan negative completely without any abnormality on their MRI scan. 68% have some evidence of functional motor or sensory disorder. And Hoover's sign again, in patients with leg weakness particularly, 16, 42 and 71%. So there's definitely a flavour here that this could be associated with functional disorders, at least in some patients. How would that work? Well, the people that have looked at Fowler syndrome have actually sort of worked this out for us, and this is how paruresis works as well. So basically, we talked about the external urethral sphincter, we talked about the fact that it's under voluntary control. When you squeeze it, so as some of you might be doing now, because I'm making you think about your bladder, and when that happens, then you become more aware of it. So when you squeeze it, you give inhibitory signals to your sacral cord. And the sacral cord then passes that up to the pontine micturition center and the periaqueductal gray. And what that does is it raises your micturition threshold. So normally about 400 mils, your bladder sort of starts to say we should probably start to look for a bathroom. But if you squeeze that external urethral sphincter, you push up the micturition threshold and you stop noticing it. And again, we all know this because we've all been very busy at work, and at the end of 8 hours, you've suddenly realized, blimmin' heck, I haven't peed all day, and you probably haven't eaten or done anything else either, but you definitely haven't peed and you didn't notice, okay? So you can have this painless urinary retention. Now, in our patients, whenever we're looking at all of these things, patients with Fowler syndrome that have got chronic pain disorders, patients that have got acute urinary retention with cauda equina syndrome, there are other things. We've talked about dissociation. Again, in the positive study, dissociation was much more likely. Panic attacks were significantly more likely to occur in patients that had scan-negative versus scan-positive cauda equina syndrome. Pain, and you can see, because we've talked about this being a feedback mechanism, you can have top-down and bottom-up impacts. So from the top down, we've got drugs like opiates, we've got dissociation, we've got pain, we've got distress, and then from the bottom up, again, drugs, opiates, imipramine, these other kind of things. Prior bladder dysfunction, and I mean, we really need to think about that because we often don't start at the beginning asking, what's your normal bladder function like? And in 1 in 3 women and 1 in 10 men, they're going to have some bladder dysfunction as a premorbid status. And then again, injury or pain, you're clenching that internal urethral sphincter. And with the brain, what we're thinking about is answering those 2 questions. Is it safe and is it socially acceptable? And all of these things, opiates, dissociation, pain, distress, the answer to those things is always no. So that is inhibiting, and that's how we think you can get functional bladder, functional urinary retention. So just 2 slides on other types of bladder dysfunction, and that's because it's a functional disorders talk, and I can't do one without mentioning volume knobs being turned up, okay? So the 2 that really are about volume knobs being turned up rather than inhibition are interstitial cystitis or bladder pain syndrome. Now, this very, very much was in the realm of pathophysiological disorders, and in fact, the mouse model for this is mice being given cyclophosphamide. But whenever they've started to take a step back and have a look, only 5 to 10% of people that have this disorder actually have any pathology on bladder biopsy. And the vast majority of patients actually have something that seems much more like a kind of volume increased pain syndrome. And patients describe pain on bladder filling, which then resolves whenever they are able to pee. And as well as that, then they have symptoms like urgency or frequency, things like that. 75% of patients will have some sort of comorbid functional disorder. Idiopathic overactive bladder syndrome, again, it's all about volume knobs being turned up. People have discomfort, they're aware of their bladder filling, they're much more likely they go more frequently to the bathroom, they have more urgency, and again, it all seems to be volume knobs turned up. And there's, again, a very sort of strong relationship between this and comorbid functional disorders. And this is the clinically useful bit that you probably stayed to listen to, okay? And so I've got to be honest, my research is mostly about phenotyping, okay? So this is just what I think is sort of relatively sensible things that we should be doing. So the first thing is ask. Now, I call this the square of despair, okay? So micturition, defecation, death, and sex, okay? Right, and let's just call them what they are, right? Peeing, pooing, death, and sex. Now, I'm fine up here talking to you about this, but, you know, if we were to go outside and I was to corner any of you and ask you about your bladder symptoms, you would probably bloody go and hide, maybe even in the toilet, right? Okay, so, and that's the big thing. So even whenever we did a study of cauda-equina syndrome in the department, and we said, you guys, you need to ask more people about sexual dysfunction because this is one of the clinical criteria, when we re-audited, nobody was asking about it. There's still really massive amounts of discomfort. But far more important than our discomfort is patients. So when you look at patients with neurological disease, where these things are commonly affected, MS, Parkinson's disease, spinal cord injury, patients again and again are talking about the importance of these things. If you can go along life with just thinking your bladder's a bag and you don't need to worry about it, it's fine. But as soon as any of these things start to be affected, it has a massive impact on your life. The next thing is explain. Now, I was at a talk recently and somebody drew, it was about functional motor disorders, but they drew a picture of an arm and a brain. And I think that's actually where we should start. We should start with a picture of the bladder and the brain and then explain that this is a feedback loop. And again, just talking about looking at all these things that are probably having effect on the top and on the bottom and explaining that to patients. And that then makes it easier then to describe how we should go forward, what are the things we should be addressing and looking out for. And always, of course, it's a software problem. And that does mean that it's actually amenable to treatment. It's really important to know that because, as I said, paruresis, shy bladder syndrome, massive impact on people's lives. Cognitive behavioural therapy has really good outcomes with that. Fowler syndrome, again, massive impact on people's lives. Sacral neuromodulation, within hours, people are able to pee again. So these are things where if we can have an impact on the functional disorder, we can improve people's quality of life. We can make their symptoms better. Now, this is just a slide to remind me to tell you that when somebody's been through any sort of pain process, if they have chronic pain, they are probably on a whole heap of drugs that are affecting the bladder. If I am to take 20 tramadol today, I'm going to be in urinary retention, okay? And so you just have to think, look at them again. I know this is the BMPA, so John was like, don't labour biopsychosocial too much. He was like, he's just like, it's a bit talking to the convertant. So, but what I just would say is look at the biological and the psychological and the social and put it all together. Just remember this, the cardinal rule of functional disorders, physios are magic, okay? And they're magical in many ways, okay? They're magical because, first of all, they can treat patients. So pelvic floor physios, women's health physios, urology physios, they have about 100 different names, so you have to find out what the right name is and call the person on the phone. They're very used to dealing with women and with people that have got chronic pelvic pain disorders. And if you sort of frame it in those kind of terms, then it becomes less scary for them and they're much more likely to get on board with you. And they're absolutely fantastic. The other thing that physiotherapy does as well is it's a way in as well. So if you have a patient who's very resistant, you've drawn your picture of the brain, you've drawn your picture of the bladder, you've explained beautifully why this is a biopsychosocial problem and you have to look at the bio and the psycho and the social, but they really just want to focus on the biology because in all fairness, if I had urinary retention, you'd have to really convince me that there's something going on that I don't just need biological treatment for. So oftentimes, if you treat with physiotherapy, you can then go on to offer psychological therapy once the patient trusts you. So as I said, psychology, CBT for paruresis. There aren't any trials of CBT for Fowler syndrome or chronic idiopathic urinary retention, but certainly in older literature, it was used for idiopathic urinary retention. And it's only case series and it's only case studies, but it does seem to be relatively effective. And again, this is biopsychosocial, so think about medications, sort of both taking them away gradually and also starting them. Think about neuromodulation, which does seem to work very well in certain patients. And the way that this works is basically, as I said, the urethral sphincter is inhibiting that sacral cord, so the messages aren't getting up to the periaqueductal gray. And what the neuromodulator does effectively is just sort of override that inhibition. So that's why it's a very useful treatment for some patients. And again, Botox reduces down that overactivity. You're turning down the volume knobs. So just think about a bit of everything. This is my book chapter from the fantastic handbook of clinical neurology, looking at functional disorders. If you ever have any questions about any functional disorder, go there first. It has everything in it. It's brilliant. And then this is another sort of, I think, important point is that fact sheets are great. So people sort of believe you at the end of your consultation, but if you can then print out a fact sheet, then people really believe you, and they know that you're not just making it up. Look, someone else has written this down, and this fact sheet is particularly helpful because it's got a patient story in it as well that people will recognise. And we're not overselling this. We're not saying definitely 100% we have all the answers here. We're just saying there are some things here that suggest that at least some of these patients have functional disorder. There's certainly something that suggests that a lot of these patients have comorbid functional disorders, and we need to look at patients in a bit more detail, and we can explain things in a way which makes sense. So thanks very much to my amazing team that I work with in Edinburgh and to all the patients. Thank you very much.